Okay, my talk is going to be about the impact valgus femoral neck fracture. So we're going to discuss about the choice of treatment. Let's start with the case. This case was a 70-year-old female independent ambulator with no underlying disease. The X-ray show like this. Okay, you see the impaction on the lateral cortex. I'm not seeing the fracture on the medial cortex, so it's going to be Gardner type 1 or maybe 2. So the treatment of choice, maybe who's going to choose conservative treatment for this case? Please raise your hand. No. Internal fixation, please. Maybe half, right? Arthroplasty, some. Okay, there are some. So mostly it's internal fixation or not enough information. So the next case, okay, obviously it's Gardner type 2, right? And we have the lateral crossable X-ray. So conservative treatment, no. Internal fixation, some. Arthroplasty, okay, most of the audience. So I'm gonna finish my talk right now. Okay. Okay, so there's many questions about this topic. So do you really know about the Gardner classification? Gardner type 1, does it really exist? Conservative treatment still an option for this subgroup of patients or not? Or Gardner type 1 or 2 should be fixed or not? And what are the comparative studies about these two methods of the treatment? First, the Gardner classification is based on only the AP radiograph of the hip, not account for the other modalities such as the lateral crossable or even the CT scan. So it can be divided into non-displaced group, Gardner type 1, 2, or displaced group is Gardner type 3 and 4. Gardner type 1 is myth or reality. The first study on bone 2012, they also have same question like this. So they perform the CT scan for the patient that diagnosed with Gardner type 1. And all 100%, they see complete fracture on the CT scan. The next one is published in BMC Surgery 2022 with the 800 femoral neck fracture with X-ray and CT scan. They also study about the consistency of the Gardner classification by the 4 orthopedists and 4 radiologists and found that if you separate Gardner type 1 and 2, and if you combine the Gardner type 1 and 2, they are better level of agreement, both inter and intra-observer, when you diagnose the Gardner type 1 and 2 as a whole group. And of course, the patient with Gardner type 1 that performed the treatment with arthroplasty, they found 100% of the complete fracture intraoperatively. So Gardner type 1 may not be exist in the real life, right? Because the incomplete fracture we usually see in the pediatric with the thick periosteum, right? But for the elderly with the osteoporosis, so may not be true. What about the role of the conservative treatment? Okay, this is the first study that show out the outcome of the non-operative treatment by the bed rest and partial with bearing. They found the secondary displacement 14%. But recently, there are many papers report the outcome of the conservative treatment and show that the rate of secondary displacement is up to 46%. So, of course, if we compare the conservative treatment and any term of surgery, there are the systematic review that also confirm that favor surgical treatment in terms of union, secondary displacement, bed rest related complication, 1-year mortality, and also the reoperative. So, at first, the Gardner classification guide us about the choice of treatment, right? If the non-displaced group, of course, they recommend to do the internal fixation. If displaced, we're going to go for the arthroplasty. So, for the internal fixation, the goal is just inside to create compression, increase the fracture severity, aim for promote bone healing and prevent the displacement, right? What about the outcome of the internal fixation in this group of patients? Okay, first study found that the revision rate is 8 to 19%. The second paper is a phase trial published in Lancet 2017. Revision rate on the patient fixed with multiple screw is 20%. Treated with sliding hip screw is 22%. And the last one is there are no notable difference between both groups. What about femoral neck system, the new implant that just launched recent year? So the result is like a comparable outcome with the multiple screw and the dynamic hip screw, but with the shorter operative time. What are the complications of internal fixation? Of course, okay, secondary displacement maybe happen, implant failure such as a cutout, non-union, and avascular necrosis, also the complication in this group. That all of these lead to the reoperation to be converted to arthroplasty, right? So what are the effects that has factor that had an effect on the posterior tube? So let's look at this case. So, and the lateral radiograph show the posterior tube, right? And if we do the templating, like the picture on the right, you're going to see that if you do the multiple screw, the end of the screw will end at the very anterior part of the neck, and it's not look stable enough, right? Because it ends in the just few portion of the head, not entire the head. This digital templating is introduced by one of our fellowship from Philippines, Dr. Camille. Yeah. And so one of the most widely used methods for measurement of the posterior tube is published by Dr. Palm in Acta Orthopedic 2009. They use the mid-column line, which mark the most narrowest part of the neck, and the two lines 5 mm above and below, and draw the line perpendicular to this line. And the second is the radial column line. So use this intersection as the degree of the posterior tube. This paper also show that patient with Guardian type 1 and 2 and treat with parallel screw, the reoperation rate within 1 year for the patient with posterior tube more than 20 degrees is 56% compared with the tube less than 20 degrees, significantly. And the other papers published in JBJS 2019, this is a secondary analysis of the phase trial that published in Lancet. This study is about the multiple screw and also dynamic hip screw, that is our implant that we use, right? So the patient with the tilt more than 20 degrees have a rate of revision 22.4% compared with 11.9%, with hazard ratio of 2.22. Okay, so the other factors in this study also show that the advanced age more than 80 also have an effect on the failure with the reoperation. Okay, so the posterior tube is one of the widely accepted factors for the fixation failure and the need for reoperation. So what about the comparable study between these two groups, internal fixation and arthroplasty? In JBJS American Journal 2019, multi-center RCT, the primary outcome is Harris hip score, secondary mobility, pain, quality of life. Harris hip score is equal, but for the time up go, mobility, hip pain is not. Quality of life is better with the arthroplasty group. And of course, complication in the screw fixation group is significantly higher than arthroplasty group. That also lead to the higher rate of the reoperation. There are also the systematic review and meta-analysis on 2019. For the topic with the favor arthroplasty group is reoperation is less in arthroplasty group than fixation. But the length of stay and operative time is favor internal fixation. By the way, no difference between 1 month and 1 year mortality and Harris hip score between these two groups. By the way, I have to say that this study that used the comparative study of the internal fixation and arthroplasty didn't exclude the factors that already proved that has a lot of fixation failure and reoperation that is a posterior tube, so further investigation is needed. So for summary, and this is also my practice right now, for the non-displaced femoral neck fracture, it's good Guardian 1 and 2. If the patient is not fit enough, okay, conservative treatment is the treatment of choice. But if the patient is fit enough, I look at the posterior tube. If the posterior tube is less than 20, I'm going to go for internal fixation. If posterior tube more than 20, I'm going to go for arthroplasty. Thank you very much for your attention.